Hi Hugh, thanks for talking to me today. Can I just ask you to introduce yourself?
Hello, I'm Hugh Brown. I'm a sessional GP in Ayrshire now, having been 30 years a partner in one of the most deprived practices in Scotland. I've had an interest in cancer for a number of years and was a previous chair of the primary care cancer group in Scotland. And I was vice chair of the guideline redraft last time round.
So we're going to talk about the referral guidelines for children and young people today. Can we just first of all clarify what age we're talking about?
So up to the age of 24, we used to call these children, teenager and young adults, but we've changed the terminology this time to become clearer as children and young people.
And what are the key changes to the guidance for this age group?
So we've added a bit more up-to-date data regarding diagnosis. We've put a bit more clarity around the types of cancers that can happen, that can present. There's 76 different childhood cancers. Nobody can presume to know them all. So we've put together a guideline I hope is useful in primary care, highlighting the main symptoms and the areas of concern that should move people to the next stage of the journey.
And one of the things I know that's been in some of the other guidelines when I've spoken to people is guidance on what to do if you're not sure and how to assess people. Is that in these as well?
Absolutely. We've got a section on assessment of patients, looking at what tests would be appropriate in primary care, and actually looking at times when tests might not be appropriate to cause an extra delay. Not all GPs and practitioners in primary care are comfortable with venesection in children. If there's significant concern, we should not be delaying that for multiple attempts or waiting on somebody else to come back in. If the concern is there, we should be moving the patient further on in the system.
I think we talked before about some of the symptoms where they can be attributed to other things as well. Is there a highlight on some of those too?
Absolutely. We have particular concern about people misdiagnosed as a sporting injury where it's not following the expected pattern, or there's something else that raises a red flag. There's also, we talk in the guideline about people with lethargy, attributing it to mental health or to exams, and just to be aware of what else is happening in the patient's life and other symptoms. It's not always the obvious sporting injury or exam stress that's causing the decline.
I think there can be significant delays in the pathway to diagnosis for children and young adults because cancer is so rare.
Cancer is rare. Average GP practice probably diagnose a child and young person cancer every 1.5 to 2 years. So as an individual practitioner, it's not something we see particularly often, but it's about pattern recognition. It's about when things are different, we're trying to highlight. If it's not following the expected course, if somebody's repeatedly presenting that doesn't normally, and also to be aware of presentations at other bits of the system. Particularly common for people to toss up at A&E, go to 111, present to the pharmacy. They may be discussing concerns with children with their health visitor. And it's just trying to look at how many attendances there have been through the system and to raise a flag if somebody's repeatedly attending and it's not following the course you would expect.
Are there any situations where we should be making emergency referrals?
There's clearly situations where if we're concerned about a spinal cord compression or about a patient with respiratory distress, these are not things we should be waiting on. These are absolutely urgent same-day referrals, 999 in many cases, into the system. We do not want to miss a spinal cord compression where we might be threatening somebody's mobility going forward. And particularly, I think it's obvious to all clinicians if somebody's not breathing properly, their time is limited.
Is there guidance on safety netting these patients?
Absolutely. There's guidance about safety netting of patients, about reviewing and what's appropriate to be reviewed, what ones are appropriate to send on. We also talk about lymphadenopathy in particular, which is one area of significant concern, looking at when lymph nodes are concerning, the big non-tender ones in particular sites, looking at when they might not be of as much concern when there's an obvious upper respiratory tract infection and the nodes are small, trying to give some guidance as to what we can safely manage in primary care and what we should be moving on.
And are there some timelines that are faster than you'd expect for adult referral guidelines?
I think it's looking at the systems in each individual area. It may well be in some areas significant concern is a phone call to your local paediatric clinic. Every area is different in Scotland, and we'd advise people to look at their local pathway, and nobody's going to be upset if you discuss concerns with a consultant colleague if you're concerned about childhood cancer.